please close also this door now, because we want to start. Hey, please put it back. No, I don't want it here. So, good morning. I see we even have table number 4. Actually, we planned only to have 3 tables. Please, can you come here? Because otherwise our discussion structure is not in the way we want to have it. Sorry to be rather strict with this. There are at least 4 seats here. So I want to give you a warm welcome for the second round of workshops for Saturday morning. And please take your seats. Seat is missing. Can you please put a chair for the lady over there and give her over here? So then we can start. We want to try to work together how we can improve the communication between the patients and the healthcare professionals. And there is a long way to go. My colleague Gerd, probably yesterday, I arrived a little bit later, the Treat to Target initiative. Do you know all the diamonds you have seen yesterday? And if you really look at this slide, in the very end of the right corner, I have seen it was Nicola. Nicola, can you hold it like this? The slide we had, I showed to you, the Treat to Target slide. I have it on my computer, but I did not want to show too many slides. But I can show it also to you on this paper version. This is the Treat to Target algorithm, which was developed by Eular, and it's very famous. You know, it's covering everything concerning low disease activity, remission, etc. This is our view, our HCP view. And here, in the very last corner, you know, nobody can really see it. There comes the shared decision with the patient. And if you go to a meeting, you know, first of all comes efficacy of a drug. Then comes safety of a drug. And then in the last round, probably, possibly, if it is a good meeting, then comes the patient. And I think this paradigm has to be changed from the very fundamental basis. And we only can do it together, that we worked out in the last workshop round. I will give you some background information, some theoretical background information, and then we will show you an example from the German Rheumaliga by Peter Böhm. And then we will have our workshop, but before we have our play role with HCP, Nicola, and also Bojana. Please take your seats and show us your way how communication is nowadays very often, and you can judge whether you like it or not. Please, start. Psst, wait a minute. Wait a minute, don't start. Otherwise, the translators cannot hear you.
Good morning, Ms. Boriana. How are you feeling today?
Hello, Dr. Kirillov. I'm fine, but I have some problems that I wanted to discuss with you. My pain is growing up recently, and I'm afraid of all the side effects of my medications. I've read the list, and I'm really afraid. Also, I feel very stressed. And I was wondering if there is a technique for relaxation. In fact, I talked to my neighbor, and she said that she is visiting a yoga class, So I was thinking that it's good for me to do the same. What do you think?
Nah, I'm not quite convinced that this will work for you. You'd better you'd be better off your medication.
But my neighbor said that she feels good. I think that I can do it.
I'm afraid you have to keep taking your medication, as otherwise you'll get worse, and we don't want this to happen, aren't we?
Okay, doctor. You always treat me like a child, but okay.
I'll just give you a prescription for the new
Okay.
painkiller and see how this goes for you.
Okay. Okay. Bye. Thanks. See you next time.
So Nicola and Boriana, thank you so much for showing us how patient communication can be. Actually, I want to give you a short overview before we start with a case study by Peter Böhm. I gave this little picture into my presentation because then you better can understand why my clinic is called Schlosspark Clinic in Berlin. It is close to the Charlottenburg Castle, and if you ever come to Berlin, you can visit not only the castle but our clinic. It's very nicely located, and when I work over hours in spring, I can see the castle from my window. So it is the benefit I have to stay there until 9 or 10 sometimes. So this presentation will cover several points: the aspects of patients and the healthcare team, self-management. This will be not in the focus of today, but when we discuss the initiatives of the German Rheumaliga later, maybe we can also go to self-management and the issues which are related to introducing self-management into daily practice. Then there are different models of shared decision-making, and also what is our personal experience. Before we can start, we have to get common ground, and that is the definition. I actually want to focus mostly on the last sentence, that it is a process. Shared decision-making is a process which both patients and HCPs make a decision that takes into account the best evidence of available treatment options and the patient's values and preferences. That is very important, every word in this sentence. And we come back to it later and see how we can really live this, because it's not so easy. So, up to now, there is no measure how we can measure shared decision-making and the impact of effectiveness on improving disease management, and what is really the advantage of this intervention. And when you don't know or you can show the advantage of an intervention, there are two reasons why it is not practiced. On one hand, all physicians say, oh, it does take so much time. One reason, I have only 8 minutes per patient, so I can't do it. And the other thing is that it is somehow not at all reimbursed for the physician. So when we introduced really disease assessment in Germany, it was not accepted by the rheumatologist until we made negotiations with the insurance companies and also the German government that there will be a certain number in the catalog for the reimbursement for the general insurance, and later on also for the private insurance, that the physician is paid on top of his normal salary for seeing a patient, which is about 30 euros, and he gets another something 15 to 20 euros if he does this assessment. And you know, the acceptance from not being paid to being paid for doing assessment went from 15 to 20% to nearly 19% of all rheumatologists. That is how it works. And so I think we have to go the same way for practicing shared decision-making at the visits. So this is a new initiative of the so-called OMERACT group. OMERACT, some of you may have heard about it. It is an initiative more than 20 years old now, who works on developing outcome measured in rheumatoid arthritis. Before it was C for clinical trials, now it is mostly outcome measures for rheumatology in general. So first of all, when we met in Monterey some years ago, there was a group of English ladies, and we were all in little huts because it was from the women's movement of the 20s where we met. And then they came in, and that was my first OMRACT, all were talking about fatigue. That was in 2008. Up to that time, nobody was really interested in fatigue in patients with rheumatoid arthritis. And this was really introduced by the patients to become really part of the so-called corset measurements, which nowadays is included in every randomized clinical trials. We have data on fatigue, and I saw a patient 2 days ago, and her disease is really well controlled under biological therapy. No swollen joint, no tender joint, except maybe a little pain in one shoulder. And then I talked to her, and we did a new imaging method with her, which is called Fluorescent Optical imaging, which shows the inflammation in the hand. And before, when we did this about 1 year ago, all was inflamed. Now you couldn't see anything. And that was the occasion why I could talk with her. And I said, well, you look somehow unhappy. What is wrong? She said, well, yes, my hands are better. My inflammation seems to be controlled. By the way, her disease activity was below 2.6. But I'm still so tired. I can't even go out of the bed in the morning, and I'm tired again at 1 o'clock. So there remain a lot of problems despite good disease control and despite a joint count. And this is why this initiative of the shared decision-making group at OMRACT now this year in May will meet again at the next meeting of OMRACT in Canada. And really we are working already on this to make a new corset to find out what we should measure, that we really can represent the factors whether shared decision-making has an impact and how we can really show this. This is work underway. It's just a survey we are doing now, and OMRACT is always working like this. It makes a corset, this is mandatory. And then normally we go to the research agenda. We have to present our results there at OMRACT, and there is a voting like we will have later in the day. And then we can say this is the most important thing to continue our work. Why I'm interested in things like this. This is one of my key slides of my learning curve when I saw this key slide by Jennifer Barton, where we can see that also in relationship to disease activity, patients and physicians do not agree. You know, we also continued this. You see here the differences. What do you think in the Patients Global? And what I also worked on for 8 years now is developing a Flare Questionnaire. Because when the patient is coming in, today I'm well, but 3 weeks ago I really was in the flare. How can we detect this, especially in the interval between the visits? And now we have really a 5-point questionnaire, which we will also finish at OMRACT this year after 8 works year, where we can measure very accurately for the times in between and also at the visits, in between online, how the flare is really making change of therapy, making any intervention necessary, even a very rapid appointment with the doctor. So that is shared decision making, because we could here develop the blue curves are all identified by the doctors, are very important to characterize a flare. And you see on the other planet the patients. So this is very important that you could show that they are not on the same page for doing this. So this is a little bit older from the published evidence. There are a lot of points which we can point out for the necessity of the importance of shared decision making. And now to the next slide. In the old model, it was all paternalistic, the HCP superior, the patient in bed, and not on an eye contact level, you know, no equal. And so the new idea is really to have the clinician and the patient on the same level and really communicate at this level. Otherwise, it will not work for the future. So 4 characteristics are to mention for this. At a minimum, both patient and clinician are involved in the process. Both clinician and patient offer information, which is shared. And how this works, we will see later. And both take steps to participate in the process by expressing their treatment preferences and also their preferences for living. And then after this process comes to an end or an intermediate end, a decision is made by both of them. And then, of course, the adherence and the compliance is much, much better, as we have seen. So, but where I think is still a deficiency is the clinician has to be able to accept the legitimacy of the patient's concern, and this is a learning process. When we have seen our play role, you can imagine that this physician even did not see the patients, you know, and the patient must be prepared. That is the other side of the coin, and we will show in a minute how that could work. So my experience, despite the recommendation by Eular, by ACR, and also by the Treat to Target initiative, we cannot say, let's start shared decision making tomorrow. It is not like this. It really, clinicians have to understand the principles, and also the clinicians have to be properly trained in this. I went to Berlin Group when I was trained in Switzerland. We had this every Thursday evening after our normal clinical round, for doing us a favor, every 3 months, that was a 1-year course, this Berlin Group, and every 3 minutes we went to so-called Italian Swiss, and they gave us a nice weekend. That was a reward at that time when we really participated regularly in this Berlin Group. There we learned somehow, but Berlin is out of fashion now. Nobody is doing Berlin Groups anymore. So we have really to work on this and get properly trained. So conclude, I don't want to read this all, but for the last point, I want to underline that there is a lot of research to be done. It seems easy, but this is why I really support this OMRACT work, that we have data in the end of the day and can show also to politicians and also to payers that it makes a difference in the outcome. We just one short experience, maybe I have some more minutes. Yes. We made a so-called integrative concept some years ago together with a rehabilitation clinic and with GPs from our rheumatological clinic. And the same doctors were trained in a special way to care for the patients. So the patients who went to the rehabilitation clinic saw the same doctor they had seen before in our clinic. There was a rotation principle. So these doctors were specifically trained to speak in a special way with the patients. And then we could show, we also presented these data at Eular, that after year 1, year 2, and year 3, the outcome concerning HAC, concerning other disease outcome measures was much better in this group of patients who went to this model clinic with all our doctors than in comparison to 300 patients who went to a regular clinic. That was really very successful. Unfortunately, it had to be stopped because of financial interest in Germany, but at least we had this experience, and we just restarted now with a new model, and hopefully we can have the same good results. So I want to show you, out of a lot of good examples, especially from the UK, I want to show you this example from the University of California, San Francisco, the so-called decision aids. And there is a lot of content which we can use for our daily practice. And you can see here the involvement of rheumatoid arthritis, and what we don't want to see anymore is the involvement to the right. So what can we do? We can ask the patient, please prepare for the doctor's visit. And this is what we did also in our clinic. We gave the inpatients a sheet of paper where they could write down their questions for the daily visit. And then my young doctors got very angry because the patients came with 10 questions every day. And then it took 2 hours to see 15 patients. It could not work. Then afterwards, I cut the paper for half of it, and I put 3 bullet points on it. And now everybody is happy. They have 3 questions every day, and the young doctors can manage it. And the next day, they can have another 3 questions. So you always have to be have a lot of fantasy to go. But this is very important. Make your list of questions, really communicate to the doctor how you feel, and request the interest. You know, it is your right that the doctor, at the moment of the visit, that you are in the focus of his interest, and that he's not writing in the computer like this and looking not at you, you know. Actually, if you encounter a doctor who is writing into the computer while you come, please, please tell the doctor that you do not want to have this, because you have at least 5 to 8 minutes with him, and if he has to write something, you can do it in the other 2 remaining minutes of the visit, you know. That is very important, but you have to learn it. Now we have a little nice and funny little video. Hopefully this will work this time. No. So what shall I do? Click on it, feeling, maybe? Yes. Maybe it will start, yes.
Do you know how to use shared decision-making when making a medical decision? Let's first take a look at how you make important everyday decisions. Think about it. Buying a car, choosing a school, or deciding where to live? I bet for any of these big decisions, you did your homework. Talked your choices through with a family member, an expert, or a friend. And I bet you weighed your options, thought about your goals and concerns, and knew what was important to you before you made your final choice. Now you're facing a medical decision. You may be nervous or even scared. But remember, like buying a car, choosing a school, or deciding where to live, the best choice for you may not be the best choice for someone else. Ask questions. Work with your healthcare team to understand your options. Know both their risks and benefits. Now you'll be able to work with your team to make a shared medical decision that's right for you. Shared decision-making is what keeps you at the center of your healthcare team.
So I want to thank you very much for listening. Maybe you have some questions now. Then please take the microphone. Otherwise, we move on with our next presentation. But any burning questions? Yes, please.
Thank you for your presentation. I would like to ask you, is there done some research about the different states of countries in Europe about the shared decision-making? And I'm quite curious about results in that.
Actually, the first survey we do is just online, and we have to answer it now. At the moment, we are the inner group for shared decision-making to get all the results all over Europe. And then we will send it out to all other interested healthcare professionals and patients. And maybe after the OMERACT, I can answer your question. At the moment, there is no real research done in rheumatology. I have some data from the literature on shared decision-making because there was a publication by the so-called Health Technology Assessment about 2 years ago, and they had 2 examples in their publication. One was breast cancer and the other was rheumatoid arthritis. And there are some publications also in rheumatoid arthritis how shared decision-making was included. But to be honest, it was arbitrary. It was not like, let me say, swollen joint counts or like fatigue up to now. So actually, I think this is a new road where we are on, and maybe we have to wait another 1 or 2 years, but we have to advocacy this. I think that's very important to bring it to political, like Arthritis Ireland, we learned so much from you yesterday. Maybe we can also do this way in other countries to request it. Okay? So more questions? Yes, please. Just a minute, I have to give you the microphone, otherwise. Okay. I get stress with the technicians. No, he just can talk.
Bulgarian.
Okay. Maybe you can translate.
Първо бих искал да ви поздравя за
I would like to first thank you for this presentation.
Can you translate, please? The earphones on?
Yes, you can. There, over there.
Окей?
Which channel? Channel 3? 2. Okay, thank you.
Най-напред
So again, let me thank you and congratulate you on this presentation. I fully subscribe to what you said. I would like to ask you one thing, but it has two subtexts. What is actually the place and role of trust between patient and doctor, and the patient narrative in shared decision-making? Thank you.
To come to one point is the patient's trust. Actually, I think trust is a thing that has to evolve over time, you know. You cannot expect that this is really there in the first encounter. Normally, I try to ask a lot of contextual factors of my patients, and then, for instance, they see that I'm interested in their life, whether they have children, what is their work. And I have a very good example for something which changed my behavior. We are covering data for the so-called German registry every year. Always in January, February, when the patient comes the first time, they have to fill on about 10 to 15 sheets on paper or on the computer, whatever they want. And then we also have an equivalent to the HAQ, you know, or the HAQ, Health Assessment Questionnaire. We have the so-called Hannover Bogen, which covers the same. It's nearly the same questions. And up to 2 years ago, I never looked into these papers, to be very honest. And I took them to the computer, and in the afternoon, we put it into the computer. Since then, when I started working with patients in several initiatives, I changed my behavior. And while the patient is there, I really looked it up page by page. It takes some time in the beginning of the year, but then the patient told me, oh, you are really interested in what I wrote. I never expected this. And then that was really, really a good start of building up trust, you know.
точно в този контекст беше въпроса ми.
This is exactly my point, because trust is triggered at the first meeting. When I walk into a doctor's office and the doctor is counting the flies or enjoying the flowers through his window, then I understand that I'm just a diagnosis, and in the moment he would rather do anything else but not look at me. I have been through this many times, but when I am met by somebody who starts on another line of behavior, then I feel that I can trust them, and I open up to this professional. And that's why I asked you about this trust between the two figures, but also the role of the narrative, what the patient tells the doctor. And you have largely answered my questions.
One more question. Take the microphone. In English?
Thank you. Just wanted to ask about the homework that patients need to do before the visit to the doctor and the research. What would be your advice to them or to organizations like our Fibromyalgia Action UK to tell the patients how to do that research? Because there is lots of rubbish out there on the internet, lots of sales speech, you know, for products and really misleading information. I think organizations, like lots of organizations, we have the responsibility to point the patients in the right direction, and it's very hard, especially if you talk about some conditions. There's not much proper research in the books, in the libraries, and on the internet you can really get so much confusing information, and it could be confusing for the patient. How would you, just in short points, explain to the patient how to find good research, something that is really worth reading?
So 2 points. One point is that you are condition which is not generally acknowledged as a condition. Your condition, fibromyalgia. It's really difficult, and I have a lot of patients who are really suffering from this condition, and we have a very specific treatment which we perform with them once a year. And I did also several clinical trials, and even with very, very difficult approaches. But what I learned from this trial is that at the moment we don't understand anything. I saw some very nice imaging pictures of neuroimaging on fibromyalgia last year at the ACR conferences. But we rheumatologists have to admit that our knowledge is very, very little on this disease. And it's a whole complex disease. I tried to find antibodies for fibromyalgia. I did so many research on this. So it's really difficult. So this is what we are. And so we have a lot of discussions with other doctors and also with rehabilitation clinics, with pension funds, etc. Because if they hear the word, you know, they see red. That is one problem. But coming back to your real question, we have on our German Society of Rheumatology, and maybe the other societies have also done this, really given a good explanation on this disease and on the contextual factors and on the possibilities of treatment. So actually, I can't give you another advice than our German society. Unfortunately, I think it's mostly in German. But the German Rheumaliga has also given very nice books about this, which are really very productive, you know, but they are unfortunately in German. But maybe you can give to the British Society of Rheumatology these examples, and they can follow it. So at least we have some explanation. We have no good treatment. That is really difficult. Yes, microphone. And then we have to go on with the next presentation with Peter. Peter, please get yourself ready. Thank you.
Early in your presentation, you mentioned paying rheumatologists some extra money in order to facilitate them doing something. I didn't understand what you were paying them extra money
okay.
for.
I will explain it. You know, assessment, disease activity score, SDI, CDI, BASDI, etc., etc. Before, it was not paid for. The normal doctor gets about 30 euros per consultation for 3 months in Germany. And if they do this assessment, it takes extra time, of course. It takes about 5 to 10 minutes, I think. But nowadays, we did all these negotiations over years with the insurance companies. They get on their normal sum they get for seeing a patient, they get an extra money, let me say 15 euros per 3 months if they do this. Of course, this is quite a lot, but it changed their behavior.
And so are you suggesting that that extra money then is maintained once you've changed the behavior? Or are you saying that actually this is normal behavior, this should be normal behavior? Actually,
to be honest, if you do a survey all over Europe and you ask who is doing assessment regularly, despite it is not paid for, they don't do it. I know it from the Netherlands. There it is done by the nurses. That's very efficient. But there are many other countries where the regular assessment is not performed. So my idea is, to answer your question, of course it should be kept, being paid for. Otherwise it is not a nice incentive if you start paying it and then you take away the money.
Okay. It's just in the UK, the very first thing you do when you see your rheumatologist is you go in and you get the assessments done before they even properly start talking to you.
But talk to French doctors, they don't do it at all. So this is the situation in Europe. Okay?
Thank you.
Thank you. So now I want to introduce my colleague Peter Böhm from the German Rheumaliga, who's giving us a very interesting example on the work the German Rheumaliga did.
Okay, thank you. It's better now, yeah. Yeah, this research project is done on behalf of Deutsche Rheumaliga, but it is done by researcher teams from 2 German universities, the University of Halle-Saale in the east of Germany and the University of Freiburg in the south of Germany. Here is the title of the project. It's the development and evaluation of an intervention for teaching of communication skills, like you can read, for people with rheumatic diseases. And this is based on an analysis of communication-related factors of social participation. That means there are 2 parts of this project. The first part we did in last year, in 2015, and it was under the responsibility of the researcher team of the university in Halle. The department of Professor Mau with Dr. Thürolf and Dr. Lamprecht. And the title of this first part was Identification of Supporting and Obstructive Factors of Social Participation of People with Rheumatic Diseases based on a mixed methods design. That means that we did 2 things. We asked patients with rheumatic diseases by an online questionnaire about what they are thinking of situations where there are problems to communicate about their disease with other peoples, with members of their family, with strangers, with acquaintances, with their physicians, with their healthcare team members, but also with their colleagues at work, with their superiors, and with staff members of institutions and authorities, also with strange people they meet in the street. We also, this is the second method, asked experts of the German Rheuma League, social workers, by a telephone interviews. And we interviewed them and asked them the same questions. What are they thinking? What are the problems in communication of patients with other people? And then when we get the results of this study, there was a second part. We did it in this year, in 2016. And this is under the responsibility of the University of Freiburg, the department of Professor Farin Glattacker with Dr. Schöpf and Dr. Schlöffel. And this part is a development and evaluation of a communication skills training to improve social participation of persons with rheumatic diseases. And the whole project, there are also involved 4 so-called research partners. Research partners are persons, they are not professional researchers. There are members of the Deutsche Rheumaliga, and there are trained members trained in doing some research work, but not professional researchers. There are 2 women from Freiburg, Ms. Kimmerle and Mrs. Joinaki, 1 woman from a self-help group in Hamburg, Mrs. Garske, and my person, I'm from Berlin. What did we do? We had a first team meeting in January last year for prepare the whole project. And the first steps then were editing and patient information for the online questionnaire, and then editing and testing the online questionnaire itself. And then to do the distribution of patient informations to patient groups and patients so that they can find this online questionnaire and they can do that questionnaire, so we get a great number of patients to answer on these topics of communication problems. And then also were made the telephone interviews by the professional researcher team, by Dr. Lamprecht, no, Dr. Thürolf. We also just begin to work on a privacy statement for patients who later on will participate at the trainings courses, and this we had to do 1 year before because we have to get the permittance of the University of Freiburg to do this course with patients, because it's a patient intervention, and before doing this we have to ask for permittance. So we had to show the privacy statement, and we had also show patient informations for the training course participants and for other interested persons of these courses. We had a second team meeting in July 2015, and we discussed the results of the questionnaire and of the interviews for developing the communication skills training. And that we do in summer 2015, we began to develop a manual for the patient communication skills training. And we decided to do this training for communication situations with healthcare team members and physicians, with colleagues and superiors at work, with acquaintances, with strangers, and with staff members of authorities and institutions. And we will let out the closer family members, because this is a great point, and we have in this training not enough time to do also this. Because we thought to do this training with a duration of 7 to 8 hours in 2 parts, one part 3 to 4 hours. And so it's possible to do the whole training at 1 day, 3.5 hours in the morning and 3.5 hours in the afternoon. But we can also divide it and do 1 day the first part, and then we have a break from 1 week or 2 weeks. So the participants of the training had the possibility to try something they learned in the first part in the meantime, and then they can talk about their experiences when we start the second part of the training. We then plan and organize the first pilot courses of this training. We had a third meeting in November 2015 with the whole researcher group. And then we organized and realized the first pilot training for see if it works. We did this in Berlin in February 2016. And the training is for 2 trainers, which will do this training with a group of patients. And in this pilot training, we mixed the trainers. There was 1 professional trainer from the researcher group and 1 from the voluntarily research partners. In this Berlin course, it was Dr. Schöpf from Freiburg and me as volunteer research partner. And in Berlin, we had a group of 7 female patients with ankylosing spondylitis. And we had a second pilot training near Freiburg with a research partner from Freiburg, Mrs. Kimmerle, and with the other professional psychologists from the Freiburg University, Dr. Schlöffel. And they did it with a group with patients with rheumatic arthritis. And after we done this, in March, we started with improvement of the training manual based on these experiences of the pilot courses, of the pilot training. Because we began to train members of self-help groups to become trainers during the evaluation phase of this communication skills training. We think that this training will be done in future not by professional trainers, but by volunteer trainers, which are members of the Deutsche Rheumaliga, members of self-help groups, and to learn to do this training by Train the Trainer seminars. And we did these seminars, and we're just doing this now in this time. And we also just start to organize and realize training courses in this evaluation phase. We have to do at least 10 training courses to evaluate the training. Better will be 12, but we have to see that we find enough groups to do this. We will do this in the south of Germany, but also in the west of Germany we have some groups to do this, and 1 training course we will do in Hamburg in the north of Germany. And there I'm involved the second time together with another research partner, with Mrs. Gaske from Hamburg. 2 volunteers in this training and not professional trainers. Then we will do, at the end of this year, the evaluation of the training courses, and if this works, we will develop a final version of the training manual based on the finding of the evaluation. And we hope we will get a good result for this. At least we hope we will have a good training to improve the communication skills, the communication abilities of patients with rheumatic diseases. And we do a lot of things during these trainings. We also learn them to prepare communication situations with their doctors, also with superiors at work, for example. We will train them to argue in a right way. There are some rules. There is, for example, the 5 points of argumentation rule. I can't explain it now because there's not enough time. But I can say, when we see our role play from the beginning, that it's not so good in your argumentation to bring the reasons of your neighbor. So you tell, my neighbor told me that for her was good that. You have to tell your own reasons and your own experiences. That would be better, for example. Then we train the participants of the training to give a good feedback, an understandable feedback. There is also a rule, the perception effect wish rule, which means that first you tell your communication partner what you percept of his behavior while you talk to him. If you take our role play, the patient could tell the doctor that she noted that he didn't look at her, that he goes around a bit with his chair, that sometimes he was shaking his head. That was her perception of his behavior, and then this made an effect on her. In this case, perhaps it's a effect that she thinks she had the impression that he didn't think that that their arguments are important, that the doctor didn't believe her if she was talking to him. And then at least she will talk him her wishes for the communication with him. So she can say, for example, if you have the feeling that my arguments are not so important or that I'm not right, I have the wish that you tell me that immediately, directly. So I can react, so I can explain it in other words better, that perhaps you can understand my point of view. That would be a way to give a feedback. To say, I noticed that you shake your head, you didn't look at me, and I have the effect that made me the effect that you don't believe me, that you don't think that it's very important what I'm saying to you, and I have the wish that you tell me this directly, if it is so, and so I can give you a better explanation for the things I want to tell you. Other thing is to say no in an acceptable way, the plus, minus, minus, plus rule. That means to open with a positive argument, to tell your communication partner that you understand why he asks you something, but then you give a no, the first minus, and then you give an explanation, the reasons for your no, that's the second minus, and perhaps you can show at the end of the statement another solution or an alternative. That will be the second plus, but you learn to say no. We also trained the patients to explain their disease in a few words to a stranger, if they meet a stranger and are in the situation that they have to explain this, or to ask for help from strange people, and other things more. And we want to implement this training course when it's ready in self-help groups of the Deutsche Rheumaliga. And we will do this with voluntary trainers And so we have low costs for this. We have a good way to do it in self-help groups, we think. And at least we will have a good method to help patients with rheumatic diseases in relevant communication situations. With these people I told you, with healthcare team members, with doctors, with their peers and colleagues at work. Also with authorities, institutions, and with strange persons too. So now I'm finished. Thank you for your attention, and if you have questions, you may ask.
Thank you, Peter. Due to the advanced time, I would like now to break you into groups. We have 2 patient groups and 1 HCP groups, and then we can also address the questions during this group session.
You can ask me later,
yes,
because you see me.
We are here. And the task you have to perform is to talk about the key tips from the patient's view to improve the doctor-patient communication. This is the patient table, this is also a patient table, and this is an HCP table. So let's start. We had a very good experience in the last round workshop, and then afterwards the results down. So actually we have to start the discussion now because we have now 35 minutes to do this, and then we can come back and collect the results.
Okay.
Not all. Because it has not been shown at Omrock, and I have to show it first. But I can make
start if you
a
want.
selection. Yeah.
Okay. Yeah.
So they work now in their little sub.
Oh, okay. But you can sum up?
Yeah, it's okay.
Oh, okay. Oh, okay. Yeah. I would like to start with some suggestions because I'm a person to live in the Netherlands where the patient shared decision making is in a quite high level. And I think that it's the most important part that you are in good communication with your health professional in all ways. So you have to be only clear in what you want, but do preparation before you go and visit the health professional. And that's the main point, what is the most important part, I think. And when you learn that to the members of organizations you are active in, then you see a growth of acceptation of the physicians, especially the physicians, to a more speaking patient, because they like it a lot. And they see that they can see an improvement in the quality of life of a lot of people. And that's the main point, I think. Because when you have a preparation list, you can really see what will happen. And when you try to learn the way that Peter, your name and your first name? Peter. Like Peter did present it in a training course with a lot of volunteers of an organization, and I think that helps. But not only that helps, but also the possibility to have influence on the systems on universities where students are trained to get communication in it, and that's quite important that the patient will be involved in that kind of situation. And in the Netherlands there is now one university clinic having sessions where every week there is a student meets patient session, and different patients are invited to tell their story, so the students understand what happens to a person with an illness. And when you have that kind of understanding by people who will be at the other end of the table in a lot of years, then you see a lot of positive effects. And that's why I'm saying I'm happily to live in the Netherlands. I know that there is a lot of difference in other countries around us, but I like it very much the way it's happening.
May I add one thing, Joop?
Yes.
I think this checklist, what we also saw, is a brilliant thing, and I would recommend that every patient does that. But what is the reality? You go there, you've got your long checklist, and you see the face of the doctor, and he feels he's running out of time. He's got this bloody patient who has got so many questions, and this is the reality. And perhaps you are able to ask 2 or 3 things, but you will not be able to work along the whole list. I don't know what you feel, and I don't know how you can get rid of that problem.
I think it all depends of the doctor. You know, there are people and there are doctors and doctors. They are bad and they are good. And if you deal with a bad one, don't go and see that doctor anymore. I only saw very impatient and quite arrogant and ignorant doctors. And I had a situation once, it was not anything important and makes me laugh now. But anyway, that is a real situation quite recent when I was talking to a doctor and explaining something, and he interrupted me quite abruptly. And he said, "Who knows better, me or you? Who is the doctor, me and you, me or you?" It was disgusting, and that sort of attitude. But also recently I was lucky to find a very good family doctor, fantastic. And I only want to see her. I don't want to see anyone else. Even if I have to wait to see her, I will wait to see her because she listens and she will go over the 10 minutes if that needs to be. She looks at me, she does nothing else when I talk. She looks at me, she asks questions that not only related to this one problem, but also like the wider life, so she sees me as a person. And I go, as you say, well prepared, very well prepared, over prepared probably, and I explain everything, including the biochemical reactions that happen in the body and why I need that test or another test, and I get everything done as I want to, basically, and I'm happy. But that's just luck, it depends on the person, and I think culture change is needed amongst not just the two participants in all of this, so I think amongst patients and doctors and policymakers to facilitate this all.
I think you are completely right with that, you have to have a personal activity and reaction with the person in front of you. Then the communication works quite well. And I think that if you look at some persons that are arrogant, I once in the last 10 years, I once stood up and went away and say, "Goodbye, I don't want to talk with you anymore because you don't listen." And that's the main point. Afterwards, I didn't saw that person anymore, and I like that because it's quite good to give your opinion.
Sorry.
When I hear that from a doctor, I say to him, "You know better than me about medicine, but I know better than you about my body and my feelings." And then he stops, and I can tell you a real story of myself. 2009, I had a breast cancer that the doctors say you have nothing. And it's only me who was checking everything and insisted and did MRI, breast MRI on my own money, not the medical insurance company. They didn't want to pay. I find my cancer and I saved my life. And four doctors said you have nothing. So what I'm saying is to the doctors today, the patient knows better on his body and his mind. You know better in the field, but he knows better and you have to listen to him. And this is...
But the problem is that you say that because you had that experience and they still did not listen to you. And I had that as well once when I said, completely gave up, and I said, "I know my body better." But so what? It didn't work that time.
No, I insist. Today
so exactly,
I insist.
It's hard when they don't want to listen. That's why this cultural change is needed, both doctors and patients. both basically. It's not just doctors. The patients need to be prepared and take the ownership for their own diagnosis and treatment.
And I think it's all about knowledge for a patient. You have to learn everything you can about your disease to be prepared for the doctor's appointment. So we have to empower the patients.
I think...
may I add one thing? I think that's totally true. That is, empowering the patient must be informed, then certainly the patient must be prepared. But I think it is too simple just to say, well, the doctor must listen to me, because I feel the patient, the doctor will not be able to afford 10 patients like you.
No.
Because this is not possible. You must be realistic. Let's say, time is money, also for him. This is what we must see. To my mind, another point is that we must really lobby for, that is, it is a normal thing that a patient has got a certain time when consulting a doctor, and, well, that the doctor certainly is also paid for that. Because it will not work, let's say, if he has got 10 patients like that, and each patient takes, let's say, half an hour.
No, I did not take half an hour, but I can be quite forceful, as you can see, and I state what I think and what I want. I like to get what I want, and I come to the doctor's appointment with this attitude, but very polite, very nice, but I think I probably give the impression that I will not back off until I will get what I want. And I make the arguments with the research I've been doing before, and the research I was doing before, it was quite in-depth, so I would read all the books that are in the local library about the disease and other related conditions and everything that's related about the condition that I have, and also lots of research on the internet. And as I say, I would go to the deep details, and I would get the tests that are not normally being done in the UK, because I will explain the biochemical reactions in the body and how one hormone and another influence another, and that's it. And if a doctor is faced with a patient like that, there is no chance other than treat properly.
When I see the doctor impatient, so I say, listen, I need that 1, 2, 3, 4 examinations, and that's it. Give me the
Prescription?
yes, and that's it. And I go, and so I don't take much of his time, but I know that I'll be treated properly, because I know what will have with me, and that's the main thing.
Yeah, but that's the research you've done before, so you know what
Yeah,
treatment or tests you need.
Yeah.
In Slovenia, we started last year a school for newly diagnosed patient with ERA. It takes place once a month, 3 or 4 hours, and where a rheumatologist and a nurse say something about the disease, and then it also present our society. On the internet is such a more information about diseases that such a workshop like that is very welcome, I think. And it's quite good for newly patient that knows the information from the first hand.
So have you already found a tip for the improvement?
Yes, we found the panacea.
Okay.
Stubborn. About 1, 2, 3, 4, 5, 6, 7, 8, 9 tips.
Oh, that's
But I would like to say...
I could take another example. In Sweden, we have a new legislation, patient right legislation, not right, but it's a patient law. And in that you could read that the physicians or the doctors need to certain that the patient has understand everything, every information, so they need to secure that. Not have the responsibility to inform, but secure that the patient really understand. And they have evaluated that legislation now, and sadly we need to say that many of the county councils hasn't implemented the legislation yet, because it takes time. I think it's like for a year or something we have that legislation, but it's definitely a way to address the issue and the questions about the patient rights and the patient's right for the information. So I think it's maybe a good start, but you need to do so much more. We need to do much more from the organizations, the patient organizations, and on the political level they need to discuss the issue also. But it could help.
Just wanted to add that basically sometimes there is this sort of understanding between patients and healthcare professionals and the politicians that the doctors know better, and that if you go to a doctor you get a magic pill, but there is not such a thing like a magic pill for a chronic condition. It's mainly on the side of the patient to do the work at home to get better, and this is the sort of change in understanding that is needed to be done.
But I think that's also very important that you know what is going on in the members of your association. That's why we started last year, at the end of last year, a small survey of only 6 questions where we asked the members, how do you think, and give us a figure for it, about the communication quality of the health professional you are speaking to. And we also asked them about how do you think you are doing that kind of communication to your health professional. And also, do you have the ability to see a specialized nurse for extra attention and extra care about it? And what the results were quite lovely to see. When you look at the communication quality, there was a range, a big range from 1 to 9 in the score. But when you make an average or mean of it, then you see that they score above 7, 7.5. So the quality of communication skills of the physicians is on a good level, I think. There are exceptions, but mainly it's on a good level. And when you look at the quality the people think they have in communicating with their physician or a health professional, they score a little bit less, 6.5. And that's quite a good reason to make a program for your members, how to inform them, give them a kind of education and training to learn a little bit more about the way to go to the visit of a physician.
You're speaking for the Netherlands?
Yes, I'm speaking for the Netherlands. Yes, I'm quite happy to live there. Yes. Yeah. And then what you see is that what is quite a normal thing we would expect is that the mean age of people that reacted on the survey was a little bit higher than 40 until 70 plus. That was the main group, and that's why I want to try to do it again with the same questionnaire, to do it by email and then look and the difference between ages, and that's quite interesting because we are changing as an organization by communication by email and not by paper anymore.
Would you mind writing down?
Oh yes, I will.
In blue, please.
Yeah, in blue?
Yes, please. There is blue.
Okay. Is it okay when I write down stand up for your rights? Human perspective. Prepare.
Preparation, yeah.
Listen and answer. And empowerment of patients and health professionals. Both. I think you need both. Otherwise you can't go any further. Keep informed about your own illness. Know your own illness. That's important, I think. And train your members, especially new members, for doing things like they have done in Yugoslavia. That's a quite good example, I think.
Can we also add patients' responsibility?
Oh yes.
This is the magic pill example, they need to feel the ownership of it.
Yeah. Perfect. I will write it out. So do you want to add something extra?
Yeah.
Is that correct?
Yes.
Yeah?
Oh, one hour. Das ist ein L zu viel.
When we have written the statements, okay, when I'm relaxed. Musst du da hinten am Tisch und kämpfen,
Oh.
Wenn Sie junger Doktor bei uns in der Klinik und der mit dem wir gestern Abend saßen, dann hätten Sie jetzt schon einen Rüffel gekriegt, ja. Naja, ich habe mir gedacht, dass das Mädchen das macht. Weil die sind ja auch eine Patientengruppe.
Ja.
Und da sollte sie eigentlich aufschreiben.
Ach so.
Patientenvertreter.
Ach so. Jetzt kann auch ruhig er auch mal was machen.
Ja, nee, der hat ja schon. Der hat ja genug Stage gekriegt, der Kleine, ja. Also der ist ja noch erstes Semester und so ähnlich. Ne?
Also,
Was?
der Doktorrolle kann man sich hier noch nicht vorstellen.
Nein, noch gar nicht. Und bei uns ist es ja so, wir machen ja jeden Morgen eine Besprechung, die ist aber auch sozusagen zur Nacherzählung da. Ja? Neues hat sich einer für irgendeinen Kurs angemeldet, war okay für ihn. Ja, darum haben wir den Rattendämpfer mitgebracht. Ich gesagt, aber er hätte warten müssen, bis ich die Anteile. Weil ich wollte eigentlich das Mädchen nicht mitbewerben. Völlig überzogen. Ja, aber ist egal.
Also so Menschen gibt es, das ist
Ja, aber der wird auch noch geschliffen. Pass mal auf.
Das ist ja nur ein
Brauchen nur einen richtigen Chef zu haben, dann läuft das. Ja, das war richtig. Also ich bin ja ganz offen mit meinen jungen Leuten, wirklich sehr offen. Aber die müssen alle vorher fragen, wenn sie was machen. Dann wissen die alle für irgendeine Fortbildung haben. Am besten noch von der Industrie. Weißt du? Dann gehe ich über den Weg. Ja, und dann soll ich noch was unterschreiben, ohne dass sie mich vorher gefragt haben.
Vielleicht machen Sie mal ein halbes Jahr für Bulgarien.
Ein Kurs?
Ja.
Ich bin ja schon Gastprofessorin in Voronezh.
Ah ja.
Das ist ja auch schon
Ach so, das ist ja weit, ja.
Ja, aber mache ich gerne.
Na schön, ja. Toll, ja.
So we come back to the
One L too much. Responsibility.
Our responsibility. Oh yes, I see. Oh, sorry.
Not so important.
Billy is okay. Yes.
We have the red table, Bulgaria.
I like
We
to
have the
speak
blue
English, but
table,
writing is a little
also
bit less.
patients. And we have 3 points from the HCP table. Maybe we have more points to come? Okay, then, yeah, but we have to resume now. Yes, I want Boriana to present the Bulgarian group results. And please, just a minute.
Okay.
Is the green table ready or shall we wait two more minutes? 2 more minutes. Okay, we wait. This is Bulgarian Society of Rheumatology? Yes. Patient organization.
Oh God.
What is? So tired?
I'm tired.
3 minutes over. Now we go on with the resume of the results. And first of all, our nice host country, Bulgaria, which is so beautiful and sunny. And Boriana will present the results from the patient's table.
Okay, I participated in the first group, the same workshop. So the conclusions are almost the same. We decided that the patient should be prepared. This means the patient should prepare some questions before the visit, or should have a diary. We discussed this. It is nice to have a diary in order to explain the doctor what's his real condition. You know that we forget sometimes. The next point is to be not afraid to ask questions, to be demanding. The next point is to be educated and aware of his condition. Before going to the doctor, it is good to read something about your condition in order to know what to ask. Also, people who are not so confident, let's say, they can have with them a family member, especially when we talk about children, they go to the doctor with their parent. And this is a new point, the last one. People who have language problems, we mean minorities, because there are some in Bulgaria, in Germany also. They also can go to the doctor together with someone who can translate.
Okay. Thank you, Boriana. Anything to add from the table? Did you forget anything? No, all covered. So thank you so much.
Thank you.
Thank you. So we now go to the blue patient's table, and the colleague from the Netherlands will present.
Yes, thank you.
Please.
Thank you. I think our group did say a lot like the first one, but the patient responsibility is on top. So the patient has to know that he is responsible for all his own action in the way they communicate with the health professional. And that's mainly also a main point, is the human perspective. We all are humans, so we have to respect each other. And when we're sitting to each other, we can't go and be really not nice in speaking. So that's the main point to keep on. And the preparation, that is also very good. And prepare, but don't make long lists. Make the main points you want to talk about with your health professional. Listen and answer. I think that's an open door, but I think it's the main point. Try to listen. Always you are quite nervous when you are visiting a health professional, but try to listen and remember. And when you can't do it, take somebody with you who you trust and let them remember or write it down for you. And empowering patients and health professionals. I think that's the main point. You have to learn how about your own empowerment, and you have to also let the possibility there to health professionals be trained for it. And you keep yourself informed globally. Keep yourself good informed. And know your illness. That's the main important part, I think. You have to know so you can tell about the feelings you have about your illness from your own perspective. And what is also a quite good goal, Yugoslavian members told us, they train their members, especially new members, to visit the health professionals and to come up for their own rights in doing the visit to the health professionals. And that was our group. And in the Netherlands we are quite comfortable, I can say, because we have a special program there in one university that it started, and that is student meets patient. And that's a weekly program. There the patients are in contact with students, first-year students, and that will be going on the whole education of the students, and that gives a good result because they learn to communicate with people, with normal people. Thank you.
Thank you very much. And actually, I wanted to ask the whole group whether you also agree that this is a point to be start and maybe that we can get consensus about later. I'm just looking for the statements, and I think this is a very good point. And now I will hand over the microphone to the, you have one?
I'm going to talk because
Yes.
you said you like my voice. So
Thank
I'm going
you.
to talk.
Yes.
As the HCP table, we are very, very happy to hear that the patients are so willing to take responsibility for their condition and that they're willing to become prepared to ask questions, because the two main concerns we have as HCP table is the time it takes to meet patients and the time, because obviously, as Rieke was saying before, time is money, and it's actually, it all becomes very cost ineffective if it takes too much time. And so the next point we had, consultations. In order to manage the time, consultations have to be specific. We then talked about there's a difference between the different consultations. The first consultation is the one where we don't have to be so specific. We have a bit more time. We can talk a bit more about the history of the person, so we can understand the background. We can understand how different parts of the person's history can relate to the condition. That would help the individual understand what the condition's all about. So that was a very important thing. But it was very important also for the HCP to become well educated on what support networks and self-help groups were available in the area so that they could direct individuals after the initial meeting to those self-help groups. Because without that, it becomes very hard for patients to come in well-informed in the future. So part of it was making sure that the HCP has those tools available to them as well. And the final point we've written down is speak the same language as patients. Often patients want a few more answers. They want to know a bit more about the drug they're being asked to take. And even if it just meant the doctor could just explain very briefly in what we in England call plain English, but plain language, what a drug might mean taking or what the condition might eventually turn out without using the complex language would be helpful from time to time. I think, have I missed anything? We also spent a lot of time at the beginning talking about the different interest of, when you talk about healthcare professional, you have the wider healthcare team involving the hospital as well, and how the hospital's interests might be different to the professional's interest. So I think we'll leave that off the table, but that we recognize as a different interest.
Thank you so much. I think we have a wonderful summary of all that you did in your subgroups. And now I'm very curious to see whether our work has changed behavior. So Nicola and Boriana, please come up to the stage again. Take the microphones. And is there one more microphone, please? Thank you.
How can I help you today?
Oh, Dr. Kirillov, I'm feeling a little bit stressed and I feel pain. I noticed that my pain is connected with the stress. My children sometimes are very demanding, so I was wondering if you can propose something, some technique for relaxing.
I know children can be very demanding, and this is something that all mothers have to put up with every day. I'm not really convinced that relaxation techniques could be effective in terms of reducing your pain.
I see that your you don't believe that my pain is connected with the stress I experience, but I can give you more examples. It's not just children, it's my work and everything. So I was thinking really for something that can relax me.
I'm very sorry you have been having these problems. I think that it's probably your pain that's making your stress worse. Relaxation techniques might be helpful, but I think they'll not be as effective as your medications.
Okay, and what can you propose me to change to see if it works? Unless you can offer me some relaxation techniques, maybe you can.
I know you're already taking a lot of medications, but if you stop any of your regular treatments, there is a risk for your disease to get worse, and you have more problems than you have now. So I can prescribe you a new painkiller medicine and see how it's working for you. And
okay, maybe something that I didn't try it or what?
yes, and we can see later how it's reducing the pain and if it works for your stress.
Okay, unless I didn't try that medicine, I can try, and if it doesn't work, we can talk about some relaxation techniques, for example, next time.
Yes, and don't forget we are having an appointment for the next month.
Okay, thank you
see
for
you then
reminding
and see
me.
how are you doing.
Thank you, doctor. See you next time. Bye.
So thank you, Nicola and Boriana, for this nice performance and also change of behavior by learning and doing. And hopefully you all can take part of this home. First of all, I want to thank you that you participated in this workshop, and I want to tell you that we meet at 1 o'clock again here. Yes? Yes, microphone, I get it. Just a minute. It's here. Yeah, here it is.
Thank you. I just wanted to say something that at the end, the patient didn't get what she wanted to get. The doctor prescribed just another painkiller, probably get it worse. The patient needed relaxation. At the end of the day, the doctor didn't listen. Sorry to say, doctor. So.
No, you are absolutely right. And in the other group, where we did it before, it was much better. So it's very interesting how it changes also by the actual ability to perform, you know. So maybe it is not so good to do it twice.
Normally what you do first time is the best.
It's the best. Okay, that's it. So nevertheless, I thank you very much. And we are meeting again here at 1 o'clock for the resume and for the resume. Thank you so much for your input.